My name is George Smith, and I'm an intern at the UT Health Medical and Research Center, and I'm going to be going over the treatment of the femoroacetabular impingement. The femoroacetabular impingement, also known as hip impingement, is a disease in which there is extra bone growing along one or both of the bones that come together to form the hip joint. The hip joint is a ball and socket joint. The ball being the femoral head, which is articulating with the socket being the acetabulum, which is forming a connection between the lower limbs and the pelvic girdle. The joint is surrounded by a smooth, slippery tissue known as articular cartilage and serves to reduce the amount of friction between the two bones and helping the bones easily glide across each other during movement. The types can be divided into two types known as the cam or pincer impingement. A cam impingement is when there is bony overgrowth of the femoral neck, and pincer impingement is when there is bony overgrowth on the acetabular rim. Causes for femoroacetabular impingement can be trauma to the hip or repetitive motions, but is most often due to bones of the hip joint not properly growing during a person's childhood development years, causing deformities to form as a cam or pincer spur, and can lead to joint damage or pain. Symptoms could be dull and achy pain deep within the groin area, followed by a sharp pain when turning, twisting, or squatting, sometimes associating with limping. When diagnosing for femoroacetabular impingement, a special test performed is known as an impingement test, which is also known as the FAD-IR test, which stands for flexion, adduction, and internal rotation, or the FAB-ER test, which stands for flexion, abduction, and external rotation. When performing the first test, the patient would lie supine on their back with the leg straight and relaxed. The provider would then raise the affected leg so that the hip and knee are bent at 90 degrees. While supporting the knee, the provider would then slowly guide the leg across to the patient's midline, and lastly, while keeping the knee intact, the provider would abduct the foot and calf away. If the patient is experiencing any pain in the last step, then that could indicate that the patient has a hip impingement, though it is possible that a patient may experience pain without hip impingement, so that's why the test is used on the unaffected leg as well for comparison. Other diagnosis methods may be used, such as imaging tests like X-rays, CT, and MRI scans. Once a patient has been successfully diagnosed as having femoroacetabular impingement, a patient may undergo conservative treatment or surgical treatment. When undergoing conservative treatment, remedies may include activity changes such as avoiding any activities that can cause any symptoms, non-steroidal anti-inflammatory medications such as ibuprofen to provide pain relief and reduce inflammation, and lastly, physical therapy. When undergoing surgical treatment, the most common surgical treatment undergone is arthroscopic surgery, which is in which a surgeon would be trimming and shaving the bone deformities of the acetabulum and or the femoral head. In May 2018, an article titled 2-Year Outcomes After Arthroscopic Surgery Compared to Physical Therapy for Femoroacetabular Impingement, a protocol for a randomized clinical trial, with the objective to determine the comparative effectiveness of surgery and physical therapy for femoroacetabular impingement syndrome. 80 patients from a large military hospital who were eligible for surgery were randomly selected to undergo either arthroscopic surgery or physical therapy. Patients within the rehabilitation group began a 12-session supervised clinic program for 3 weeks, with the surgical group waiting for the surgery to perform, which is averaged at around 4 weeks. Patient-reported outcomes of pain, disability, and perception of improvement were collected over a 2-year wingspan, and although there were no significant difference between the groups after the 2 years, there was a 70% crossover from physiotherapy to arthroscopic surgery. However, in January 2019, an article was published titled Arthroscopic Hip Surgery Compared with Physiotherapy and Activity Modification for the Treatment of Symptomatic Femoroacetabular Impingement, a multicenter randomized clinical trial. The trial had the same objective, but with changes such as having a higher sample size of 222 patients, and that the patients in the rehabilitation group were given a maximum of 8 physiotherapy sessions delivered over 5 months, and the study was conducted for only 8 months, as well as using the HOS-ADL, which stands for the HIP Outcome Score Activities of Daily Living Subscale, as their primary outcome measure. 8 months after treatment, patients in the surgical group had an average of 10 points higher in their HOS-ADL score when compared to the physiotherapy group. It was concluded that the patients with femoroacetabular impingement had superior results with the arthroscopic hip surgery as opposed to the activity modification or the rehabilitation in physical therapy. Lastly, another article which didn't provide any further statistical evidence to either side did show that the average cost of hip arthroscopy was $3,787, which was including staff time, surgical devices and anesthetic drugs, and theater running costs and bed day costs, when compared to the patients in a rehabilitation group with personalized hip therapy, which included an average of 6 30-minute sessions, generating only a total of $192 per individual. This came to the conclusion that personalized hip therapy was more cost-effective than hip arthroscopy at 12 months. In conclusion, for femoroacetabular impingement, there is controversy over the optimal approach that should be taken for treatment after diagnosis. However, it has been shown that arthroscopic surgery has produced higher results in daily activity when compared to physical therapy, although physical therapy has also been shown to be more cost-effective to the individual.